So I'm here today with Dr. Lara Briden. She comes to us from the other side of the world with decades of experience around women's health, hormones. In my last series, I talked to Dr. Briden about women's metabolism, and today we have a chance to talk about actually a related but different topic of sexual desire. So, Dr. Briden, thank you for being with us today.
Oh, thanks for having me again,
It's
Dawn. You can just call me Lara if you
okay,
like.
great. I can do that.
Yeah, it's just,
Um,
yeah,
so, as we dive in, I want to start with a question that I see at least a couple times a week, right? Which is
yeah,
this woman in her 40s comes in and says, I love my husband. I want
yeah,
to want to.
yeah,
Damn it if I don't. So, as I've mentioned to you, many times these women are asking for hormone therapies and they're
yeah,
often not appropriate. So I'd love to hear your thoughts on like, where do you start?
yeah. Well, my approach to almost everything, and I'm curious to hear if this is for you as a fellow clinician, it's there always has to be some troubleshooting and just thinking, what are we actually talking about here? Like not just for sexual desire, but for so many things. I'll sort of assume, okay, it's we're looking at one particular kind of problem or obstacle, and then you realize actually it's a whole other thing. So yeah, it's about, and especially if it's a patient I already know well, I might already know some of the answers, but you just need some of the first steps of just be like make sure there's um nothing that's contributing to pain, especially like something maybe more recent that's contributing to pain, like fibroids or something else that's going on or heavy flow. Those can all make sex feel not like something they want to engage in,
Well,
especially if
sometimes even
yeah,
musculoskeletal pain, right? Like I've
yes,
had women who have a hip injury or a low back problem, and they're just like,
yeah,
I just can't get comfortable in
yeah.
positions, right? It's
And
not
sometimes
always vaginal.
yeah, and sometimes it could be a male problem too. Like if a man's having sort of a health problem that he's sort of awkward about or ashamed about, it can change the whole dynamic. So they're different because that's for the first step is like there's some in many cases, fixable situations with the body that and then the next thing is actually as I'm diving into it, I often do sort of differentiate between um like is it lack of desire or lack of ability to respond the way you used to? And like one of the tests I'll get, well, I mean, you can ask about masturbation too. Like it's sort of, is masturbation still okay? Or another test I'll often ask is if you're watching a sexy movie, like the kind of thing that you used to respond to, do you still get that little, you know, glimmer of something? I mean, that's just sort of a good physiological test. Is like, is that because if that desire is still there, but then there's something sort of has changed in the marriage, obviously, then you need or in the relationship with a partner, then that's its own kind of information. I mean, sometimes just a lack of ability to respond, even if there's still the spark of desire, that can be more sort of, especially later in the phases of perimenopause, that can actually just be lack of estrogen, sort of that would be a situation for vaginal estrogen as a solution, for example, that could help. Just on the topic of vaginal estrogen and the genital urinary syndrome of menopause, even things like bladder leaking and stuff like that can be an explanation for not wanting to have sex as much because that's very embarrassing. But you see what I mean about troubleshooting. Like if that's the problem, then you think, okay, well, we need to actually treat with vaginal estrogen and help with that side of things. And then beyond that, there is next step would be, I say, troubleshooting medications that could be interfering with sexual desire. So the big ones are SSRI, antidepressants, both current use and past use, unfortunately, because there is a post SSRI sexual dysfunction, it's called, which is a kind of, I don't know if it's permanent, but some people think it might be very long term anyway, sort of dampening of, yeah, sexual desire, kind of a genital numbness people talk about from that.
With
Yeah.
that, do you know, would you likely to see a new onset of loss of desire, or if somebody was on an SSRI, let's say 5 years ago, and
Yeah.
now they're having lack of desire, is it possible that that's related, or would that have been persisting?
No, I think it would be. I don't think there wouldn't be a gap where desire was then fine and then, 5 years after the medications. No, I think no, there would be but I think the lack of desire on the medication can start sometime into it. So but once,
Got
yeah,
it.
that post SSRI, I believe it's immediately
So if
post it.
somebody's, let's say they've been taking it for 5 years and now
Yeah,
they're having lack of desire, but they're still taking it, then that could be related.
I believe so. And I'm not an expert on the SSRI side of things, but I do know there's quite a lot of discussion about that and obviously studies trying to figure out what's going on there. Other common medications that can affect sexual desire would be antihistamines, which obviously women turn to for lots of different things, including some of the perimenopause, heavy period symptoms. I've definitely been one of the people who is recommending sometimes, antihistamines can be helpful for symptoms. So just be aware this could be a flip side where they could also
Well, and
dampen.
SSRIs are sometimes recommended for
Yes.
flashes. So
Yeah,
it's all
exactly. So there could be a downside. It doesn't mean it's insurmountable, but it just is something to consider. And then also progesterone itself. And on the same topic, like I'm off as, natural progesterone or prometrium is body identical progesterone is one of my favorite treatments for heavy flow, for perimenopausal symptoms that can have a libido reducing or sexual desire reducing effect as well. So there's those things. And then sort of just going deeper, there's just medically what's going on, and especially around energy. So, as I'm sure you know, underactive thyroid is a surefire way to lose libido. So, I mean, assessing for thyroid Hashimoto's, making sure that side of things is supported, making sure iron deficiency is identified and treated. Sleep disturbance, including sleep apnea, anything that, I mean, there was this one study. I don't know if I'd be able to find it. I should have bookmarked it a bit better, but it came out a few years ago just for women, especially women in that age group. The number one, like they looked at all the different factors affecting sexual desire and libido, and they're like, actually, for women, it's really about whether they've had enough sleep on an ongoing basis, which makes sense actually, because if you're exhausted and burnt out or sleep deprived, then that is, yeah, the nervous system is not interested in something like that, and having sex at that point. So that's,
sure.
yeah,
That,
that's a
that
good
actually makes a
reason.
lot of sense because oftentimes I find that people are very resistant to scheduling or making time kind of early in the day for a sexual desire, for sexual activity.
Mm.
And so if you're getting in bed ready to go to sleep, and then your partner's like, hey, how about now? And you're like, oh my God, I like 7 hours are about to turn to 6.5 or
Well,
six.
and
That doesn't
morning can
go
be a
well.
great time for men as well. Like everyone's libido, sexual desire is going to be higher in the morning. So I mean, or the middle of the day. It doesn't have to be morning, but yeah, at some point in the day.
Do you
And
find that with women also? With men, we definitely see it with the t testosterone being higher, but do you find that with women?
I guess I don't have an easy, like a well-referenced citation for that. I mean, I can see for myself earlier in the day is much better. I mean, I think it's just an energy thing. But yeah, I don't know. Do you have any data on that? Like where
I
sort of
actually
in
don't.
terms of,
That's why I was curious. There's so much data about men, and the correlation to testosterone
yeah.
spikes, but I don't know. And I don't hear enough from my own clientele, if that's actually a preference or not. So it's
Well,
just
as you say, like scheduling it for the morning or afternoon can feel a little like there can be like a nice element to that as well. Like it can feel a little naughty. Like you do need a little naughtiness in the. I mean, I'm sure you have other experts talking about this, but like from the emotional side of things, like just feeling like it's a little illicit. You're just closing the door, turning off your phones. That's in the middle of the day. That seems like it can be a good thing. Yeah.
yeah, absolutely. How often do you think it is actually testosterone, right? Like, I'm sure you see this too, but so many women, I think there's like, it actually motivated me to do the whole series because so many women are like, I have no desire. Please let it be my testosterone. Like, please give me something to fix this. And like you've already alluded to, it's often so much deeper. We at least need to rule out the deeper before we just give the hormone. But how often do you think that somebody just needs testosterone?
Well, I think put it this way. I think testosterone can override some of those other factors. Do you know what I mean? Like I think testosterone can really push sexual desire. And I mean, it's a powerful hormone. It's an amazing hormone. So I guess, I mean, the research is, as far as my understanding is, I mean, it's pretty solid for that indication. And, women taking it for that, well, not always. I mean, some women won't get a response from it, but I think it can deliver a response, even if the underlying cause is, a bit of shame around a bladder issue, or even if there's a thyroid issue, or even, you know what I mean? Like, even if there's sleep deprivation, I think it can override that, which is both good and bad, I guess. I mean, I personally wouldn't take testosterone for that reason. But yeah, I think, what do you think? Do you have any other sort of
Yeah,
data
well,
on
I
that?
kind of find that when it works like that, I see it working for a couple of weeks and then not working as well past that, which is one
Yeah,
of the things that I was curious to see. Do you
yeah.
notice the
We
same?
we could speak a bit more about androgens generally, like so androgens being testosterone or DHEA, or how likely that is going to be needed in the perimenopause transition. We can talk about that because there's sort of this narrative that testosterone goes over the cliff as well, like with together with estrogen and progesterone, but that's not true. That's not what it does. Androgens, so male type hormones, in the group of them, are in both sexes are in just a slow and steady linear decline over our life. Like, and they peak in our early 20s, and then they just start going down. And that's true for both men and women. And what actually happens, like in a perimenopause where there's no estrogen or progesterone given back, testosterone starts to shine through. So in my perimenopause book, I did talk about the relative testosterone dominance of especially the later phases of perimenopause leading into menopause. Actually, there's relatively higher testosterone. Actually, testosterone does bump up a little bit, so it's never going to go up to what it was in its 20s, and it's on its way down. But you get this little blip with that's coming from the adrenal glands going up in a woman's 40s together, but really it's a relative situation. So then when there's not as much estrogen or progesterone around to balance it, you get testosterone shining through. And that's where we know that's happening, because that's why women get facial hair, can get like the jawline breakouts, that's actually where some of the metabolic health, insulin resistance, redistribution of body fat to visceral fat is coming from relative androgen excess in perimenopause. So um, that actually, if you actually talk to women who and experts who work with women who don't take hormone therapy, women in perimenopause technically actually can get an increased libido, um, which I think totally makes sense to me from a hormonal perspective, and anecdotally certainly is out there. That's all negated if as soon as you come on board, especially with progesterone, um, because it will dampen that effect. But you definitely hear. I mean, I do reject the idea that perimenopause it just inherently is a time of lower libido or lower testosterone, because you definitely hear of women especially in their 40s, maybe in new relationships, who have no problems whatsoever, like just like zero problems. So libido can be quite high in a woman's 40s as well.
It
So yeah,
actually brings me to this question though, before we talk about progesterone.
yeah,
What happens when you give that woman DHEA? Like, will
yeah.
she have a preference for the testosterone pathway at that point in her life?
I don't think there's any way to know that. I mean, you could test that. I mean, you could give DHEA and then sort of see which pathways that's going down. Because obviously, what you're describing is DHEA is a precursor hormone. It can go down the estrogen pathways. It can go into testosterone. Well, from yeah. So from it can stop it more at testosterone, or it can flow from testosterone into the estrogen. So I think it's just going to depend on how all those enzymes are calibrated, and it'll be in the dose, depend on the dose of DHEA as well. I personally take DHEA. I'm happy to kind of share that. I mean, that's as a little bit of androgen support now that I'm postmenopause, and that would be for mood and bone health, and maybe a little libido as well. I mean, I don't know how much data there is on DHEA and sex drive. It certainly can't, force a sex drive the way testosterone can. Um,
And then I want to put you on the spot and ask about dosage with
Yeah.
DHEA, specifically
Yeah.
because DHEA is available over the counter.
Yes, I
I think
know.
it's
In the
really
US it is.
important
Yeah.
that people understand. I think that so many people have this like, I can buy it at the natural
I
grocery
know.
store, so it must be safe. And they
Right.
take really high amounts. So, what do
Yes.
you think is a safe
Great,
amount of DHEA?
great question. I mean, I forgot because of course I'm not in the States, so I sort of forget that you guys can just get it there. In most other countries, you can't even, it's hard to even get it by prescription. But for women, I think women shouldn't take any more, like the absolute cap for women is 10 or 15 milligrams. Um, Anywhere between 5 and 15, like 1 5. I know you can get 50 milligram capsules out there. That's too much
Yeah, you
for
could get
women.
25, you can get 50.
Yeah.
One of my colleagues had a patient where a health coach put her on 100 milligrams of DHEA. Like we were all
Yeah.
floored. I was like, oh my God, I don't
Yeah.
think I've ever given somebody more than 10. I
No.
usually start with
Yeah.
5. She's like, I start with
Yeah.
2.5, right? Because,
Oh,
I find
right.
that
Interesting.
DHEA more than anything else, I'm curious if you have the same experience,
Yeah.
even when it's low, I find that giving it can agitate people.
Yep. Yep. It can cause insomnia and things like that. Is that what you mean? Like it does seem to be
Or that they
somehow
get
quite
irritable,
stimulating
that they kind of
or
jump
irritable.
to anger,
Yeah. Interesting.
So I'm
Yeah.
very cautious with it.
Yeah. I think start low. And also, I always dose it every second day. So myself, I take, so for myself, I mean, for what it's worth, I can't give it to a lot of patients because it's actually pretty hard to access here in New Zealand, even with a prescription. But, so I probably have less experience than you prescribing it all through the years. I've managed to give it here and there. Um, I take 10 milligrams every second day. So it's equivalent to 5 a day, but I'm doing that intermittent, every second day dosing, which I guess I'm just thinking, maybe doesn't, in that case, it wouldn't support the body's own production. That's sort of the idea. Yeah.
Mhm. That's so
Hmm.
useful to know. Okay, and then you were starting to say once you add progesterone into the mix.
Yeah. Well, I mean, right. I was talking about this natural shift to essentially testosterone dominance that comes with perimenopause, menopause, but as soon as you give estradiol and progesterone, you negated or treated that testosterone dominance, which is good in some ways because that can help with the insulin resistance and help with facial hair and things like that, hair loss. But it then you don't get to harness that natural increase in libido that should come with perimenopause. I mean, I've seen, and again, I can't remember exactly. I have difficulty locating them again, but I've certainly seen some social media accounts that are all about, yeah, kind of harnessing that natural increase in testosterone. I mean, maybe from a kind of makes sense, like maybe sort of prehistorically, women, are sort of more outgoing or sort of more male hormone driven into their 50s and 60s. It's interesting.
Yeah. And again, I guess I find myself with another dosing question, mostly
Okay.
because here, which I get
Yeah,
is different in New Zealand, but here, shocking to me, you can buy progesterone cream.
right.
And now I see estradiol cream
Yes.
at the natural grocery stores. And
Yeah.
so I think that people are often going, oh, I've heard this is good. I heard this can help.
Yeah.
So knowing that you're not giving any specific recommendations, like what are some of the safety limits for people? I think about in terms of like using it vaginally versus topically, how like what are the safe upper limits? And then if you are sexually active and you use it vaginally, how long do you have to wait so that your partner doesn't get a dose of estrogen?
I know. Well, with my patients, I say, because usually they're not using vaginal estrogen every night. So I would just say, don't apply it and then have sex directly after. I mean, I think maybe have sex the next day or the next afternoon or something like that. I mean, I think that's enough time, don't you think? Like 12 hours or something to absorb. And
I
yeah,
tell people have sex, go urinate, and then put your estrogen in.
right. And then put it in after. Yeah, no, I think you don't want to expose your partner to that. In terms of the safety question, yeah, that over the counter estradiol, there's usually biased, right? So it would be a estriol and estradiol. I guess I'd have to sort of look at the products and the calculation of how much estradiol that is, because it's really the estradiol that sort of matters in terms of systemic dose. And then the real safety thing would be it's unopposed estrogen. I mean, depending on, so people might also be taking a progesterone cream as well. But as you know, there are some question marks around how well a transdermal or topical progesterone can protect against the thickening of the uterine lining. So I don't know. I haven't seen any case reports of people developing thickened uterine linings from those over-the-counter estrogen creams, but I would say it's within the realm of possibility. Have you heard of that happening or
I've
anyone? Yeah.
seen that, but it's pretty new that I've even seen these things. I'd seen the progesterone
Yeah.
cream over the counter for a while. I think
Yeah.
it's pretty new that at least that I'm seeing,
Yeah.
estradiol or Biest cream at the grocery store. And so just for those of you listening, right, I think we got a little bit into the weeds, but
Yeah.
for those of you who don't know, if you have a uterus, right, it's not advisable to take estrogen without taking progesterone. And so that's sort of why we're talking about some of these safety concerns around, just trying things without supervision or, on your own. Because maybe
Yeah. I
you
take a
think, like, I have no libido, let me go try these hormones. Sometimes they're great and sometimes they're dangerous.
yeah, a takeaway would be that I would say that over the counter estrogen cream, that's enough. That could thicken the uterine lining in theory. That's enough. But the progesterone cream might not be enough to thin the uterine lining, right? Like I don't know if they can be balanced that way. Usually, I mean, well, most of the data, it is again, the research is mixed, but most of the data suggests that, or you kind of need oral natural progesterone. If you're going to use natural progesterone to protect the uterus, it should be oral or vaginal. Um, yeah,
Okay. What about moods, right? So coming
yeah,
back to the idea of sexual desire, I think that, and we can broaden this past the
yeah,
menopausal
yes,
woman,
yeah,
but I think that a lot of times anxiety, depression, just sort of mood instability becomes a barrier to connection and therefore a
yeah.
barrier to desire. So how do you approach mood balance in women? This is such a big question.
That's a whole episode. Um, I guess what comes to mind, that just to kind of tie it in a little bit, just to give an example. So certainly anecdotally, I have seen um over the decades, women feeling, and I'm sure it's valid, that progesterone cream actually improves their sex life. Even though, despite what I'm saying about how progesterone, at especially higher dose, would be suppressing to sexual desire, I think partly what's happening there is actually mood. Like, so progesterone is very as you know, it can be very soothing and kind of anti-inflammatory, and especially if it's addressing indirectly improving a Hashimoto's thyroid problem and just generally feeling better, that's going to translate into better sex drive, just generally feeling better from any reason. So, in terms of mood generally or premenstrual mood, how to tackle that, that is, again, a sort of its whole other level of troubleshooting, like what's driving the mood. Sometimes it would be kind of, just to give some examples, like a mast cell activation issue, a metabolic dysfunction, gut problems, nutrient deficiency. Straight out iron deficiency is terrible for mood in women. Obviously, that can be a cause. Um, yeah. What would you sort of add to
Well,
that or
it's just,
insert
I'm
into
kind
that?
of,
Yeah.
I'm like laughing as I ask the question, Laura, because it's like you get two naturopaths together, and of course,
Yeah, I know.
everything's connected to everything. So
I know.
it gets tricky, but yeah, I do find, I mean, adrenal dysfunction, B vitamin deficiency, like these are
Yeah.
often my go-tos. You have anxiety, let's make sure that you have B vitamins and that your adrenals are nourished.
Yeah. And I always,
Often relates to
yeah,
caffeine and sugar.
yeah. And sleep, again, to circle back to sleep quality, and especially any undetected problems with sleep. I'll just mention sleep apnea again because it's such a sinister thing. It's such a like it just robs energy and mood, and is treatable. So that would be another one to consider. I do often frame things now as the autonomic nervous system, kind of that healthy oscillation between sympathetic and parasympathetic. I want to see more information coming, or maybe it's more content. I might even try to have to produce some myself, just around. I do feel like the autonomic nervous system settings for women are quite different than for men. Like I had a series, a couple of a sequence of podcast episodes about the role of the autonomic nervous system, that parasympathetic versus sympathetic, its role in women, especially young women's tendency to hypoglycemia or low blood sugar. So whereas men just have a very quite a differently calibrated autonomic nervous system. So I feel like this, and the autonomic nervous system plays a role in especially sexual response and ability to orgasm and all those things. So I think this, yeah, the nervous system starts to become quite important. There's lots of ways to access and support the autonomic nervous system. That's where in my latest book I talk about the signals of safety. That's from the work of Stephen Porges. Like this, just all the different ways you can tell your nervous system that everything's okay. It's, not just emotionally, but physically as well. So yeah.
That's fascinating. I'm like almost embarrassed to say I've never quite considered, the adrenals and the autonomics in the
Yeah.
spectrum of sexual desire. Like with men, we learned in medical school, point, parasympathetic, shoot, sympathetic,
Right.
right? You need
Yes.
both. It's very clear.
Exactly.
And oftentimes when I'm treating a patient who has anxiety, right, like we might look to dietary sugar as just an example, because if your adrenals are constantly trying to
Yep.
normalize this
Yep.
up down, then they're sort of less available to soothe and regulate
Yep.
other aspects of mood. But I hadn't considered how that plays out, in terms of libido and the arc of
Yeah.
orgasm.
Yeah. The whole, like, yeah, the response as well. I think it's probably, well, it's both. I mean, as I said, libido and response are quite different. As you said, we could know that for men, but for women, they are as well. This is the spark of, what does watching I don't want to give an example, but like, one of your favorite, like, whoever you're attracted to on a movie, does that give you a spark of something? And versus can actually feel sensation and respond and able to orgasm? That's a different
Right.
part of the nervous system taking over.
And it actually even brings me into, I would say there's a difference between desire, arousal, and
Yep.
climax, right? Like as
Yes.
they're
Yeah.
all very different. So it's really useful to recognize.
They are. And actually, one thing I want to just insert here is, and this is, and again, I'm not not a sex therapist, so I'm not an expert on all this, but just from my work with patients and just, talking with friends and myself, I think, I feel like women shouldn't have the full expectation that they have to climax every time. You know what I mean? Like, I just feel like that adds a lot of pressure. It's already like there's already going to be pressures on this situation. It's supposed to be fun. Like it's
Yeah.
supposed to be nice. And there's lots of nice things about, I mean, sex, if you're doing it right, or if it's with the person you want, like, it with even without I mean, climax is great. And I think women should have the right to it. And certainly I hope that's in a lot of women's lives, but it doesn't have to be, it's not a to-do list. Like it's not a task to like, it's okay to have sex without climaxing.
I talked to Steven Snyder as part of this series, who wrote
Yeah.
the book Love Worth Making. And
Yeah.
he's been a
Oh,
sex
that's a nice title.
therapist and a
Yeah.
psychiatrist for 30 years. And
Hmm.
he refers to orgasm as dessert after a
Yeah.
fantastic dinner, right? And you
Right.
should enjoy every course. And like maybe you have dessert, maybe you don't. But you don't
Yeah.
go to dinner for dessert. You go to dinner for
Yeah.
a beautiful meal, and then
Yeah.
you decide if you want dessert later,
Yeah. If dessert happens, if
if
dessert
dessert happens.
arrives at the, yeah.
Yes.
Yeah. That's a great way. Hmm.
So, a question as we talk about autonomics, hormones, this
Yeah.
natural variation in libido. I'm curious about PCOS, right? Because this is an
Right.
area of focus for you. And, for those of you watching and listening, it comes with androgen dominance.
Yes.
I have not seen, and I'm curious if
No.
you have, I have not seen increased libido with my
No.
PCOS patients. So
No. And there's,
why not?
I know everyone's like scratching their heads. It's like, well, wait, that doesn't add up. What's going on here? Um, yeah, I'll touch on that. I just want to, before we just leave the topic of the autonomic nervous system, I was just going to say there's just this recent bit of research. just to illustrate how differently calibrated I think men's autonomic nervous system versus women's. So, you know, the whole ice bath plunging,
Yes.
that's working in large part because of the vagus nerve and autonomic nervous system. Um, they've just discovered that actually for men, yeah, they ice baths, you know, 2 degrees or 2 degrees Celsius, right? I can't think in Fahrenheit, but you know, the ice temperature is great. For women, it's actually totally different. It's like a whole, you know, what they've said is 16 degrees Celsius. I don't know what that would be. Like more like a summer river temperature, this story. But I just thought as soon as I saw that research, the penny just dropped. I thought, yeah, that totally makes sense. I mean, women, our nervous system is different, and what, you know, works for men in that regard is not necessarily going to work for women. So
60 degrees Fahrenheit is 16
right,
Celsius. There we go.
yeah, so it'd be like a jumping in a river kind of temperature rather than jumping in a polar you know, Arctic Ocean. So it's quite different, and I think that just fits with my
The same
experience
with
of women.
fasting, right? We're starting to
Yeah,
get more and more research around differences in the way that men
yeah,
fast and the way that women
yeah, yep.
fast.
Women, men can do the more heroic. They can get results from the just very stronger interventions, whereas women can actually get great results from quite gentle time restricted eating, for example. But circling back to PCOS, yeah, what the heck? Why are they not getting the benefits of all that testosterone? Well, not that it's that much, actually. I mean, it's still way less than men, just to put it in context. I mean, it's more,
But it's often low, it's often higher than what we might consider a therapeutic dose, right? Like
yes,
if I were giving
there's,
testosterone to a woman
yeah,
and then doing repeat labs,
their
our
serum levels
target
are,
number is lower than I often see with a PCOS patient, right? Just for
yeah, exactly. Yeah.
and
And
yet,
so I guess that's one of these questions that is um, important because if we can collectively, you know, scientists can figure out the answer to that, I think we'll have a lot more insight into women's sexual desire. Like, yeah, I think part of it could be, I'm just thinking out, I mean, I guess I don't think there's any known answer for why they're not harnessing the benefit. I mean, they might, it sort of feels like they've got so many other bad things going on with PCOS. They should at least get the benefit of, you know, increased libido.
yeah,
Um, I think I did see something, and it kind of makes sense through my biologist brain that it's, you know, under the constant stimulation of too much testosterone, you know, their receptors are just going to be less sensitive to that.
the resistance, the
Women are
testosterone
women,
resistance.
yeah, some degree. I mean, in the nerve part of the nervous system that's responding to that. I mean, women are we're cyclic beings, so I do know, for example, that in just a woman without PCOS who's ovulatory, naturally cycling, that little, if you look at the charts of what happens, there's a tiny blip of testosterone just before ovulation. It happens with the surge in estradiol. So the two things are happening together. So you can't really tease them apart, but that is associated with, I think, a pretty significant increase in sex drive at that time. Not only that, but just outgoing and just generally feeling quite euphoric. That's one thing I do miss that about, now that I'm postmenopause. I do miss the cycling. That like pre-ovulatory couple of days is like sort of almost invincible feeling. Um, I think women are sensitive to that little blip in testosterone primarily just because it's quite rare. I mean, it's only once a month. So that's an example of sensitivity. I think the other thing going on with potentially with, well, a lot of women with PCOS obviously have treatments, so they may be on, if they're on, as soon as they're on hormonal birth control, then that's all erased.
Well,
So we
and
can't
that's
really
where I was
expect,
going to
yeah,
ask you to go next, right? It's like it
yeah,
is the most common recommendation,
yeah,
especially if you're
yeah,
not working with a naturopath, that you can balance your hormones by taking
yeah,
the birth control pill. Can you once and for all not only dispel that um, hypothesis that will balance your hormones, but
yeah,
also, talk about some of those consequences specifically to sexual desire and all phases of sexual desire, right? Like the desire,
yeah,
arousal, and climax, how any aspect of that is influenced by the pill.
yeah.
Hormonal birth control, not because
I
that.
know. And I'll just warn you, it's a little more nuanced than, because I'm actually just working on, I'm writing something about this right now. So I had to kind of look at some of the current research around, we'll get to that. But first, in answer to your question, you know, can the combined estrogen methods, or what's be combined, classic combined pill, patch, ring, those are vaginal ring, those are all in the category of combined estrogen methods. You know, can they regulate the menstrual cycle or regulate hormones. I mean, obviously not, because what they actually do is switch off ovarian function and then replace. So I'm just working on a social media post about this right now. So on the combined methods like that, if you were to do a blood test for estradiol and progesterone, our two main hormones, they're at menopausal levels. Like they're completely suppressed. And in their place is ethinyl estradiol, which is different, although it is still quite, it has a strong estrogen. And then one of many progestins. And depending on the type of progestin, some of the progestins are anti-testosterone. So some of them are like suppress androgens are very suppressed on those combined methods, especially the ones with drospirenone, like so especially Yaz. So in theory, I mean those would suppress libido completely. Um, and that's what a lot of the research, I mean, what little bit of research we've had over the past decades has been, yeah, like women have report lower sex drive, testosterone is very low, something called sex hormone binding globulin is very high, which contributes to the low testosterone. And that might take years to reverse even after stopping those medications, which is part of the problem, but concerning. But when you actually look at the studies, so I was just trying to find some recent citations to kind of back this up. So there was one on combined methods where they said, yes, it suppresses sexual desire. Like that, there was a randomized control trial. So they did placebo versus combined methods, and they concluded it does, which makes sense because, I mean, if it doesn't, then nothing we know about hormones makes any sense, right? Like, but then more broadly, hormonal birth control generally, there's a real mix. And some women, and I think it's real. I mean, some women report improved sex, sexual desire, sex life improves on different methods. And I think part of that, it's going to be about, well, it's like just the relaxation of not having to worry about pregnancy. I think that's part of it. I think that's the nervous system again, especially if the hormonal birth control has relieved, pain or other, discomfort or other sort of symptoms that might have been contributing to, we talked about that at the beginning, right? Like sort of, the stats are really high. It's something like, they don't really, again, it's a very broad, anywhere between 10 or 15%, anywhere up to like 60% of women, young women, experience pain with intercourse on a regular basis. So, I think it really
Awfully.
varies depending on the study method and what they're looking at. But um, that has to be factored in because I think, pain and even just the prospect of pain is going to impact how a woman feels about sex and how well she's able to respond and how interested she is. And of course, hormonal birth control can sometimes relieve pain, but it can actually kind of cause pain. So combined methods have been linked with vaginismus. I'm sure you've heard, if I've said that right. Have you had other people talk about this where
I was actually
yeah,
curious about vaginal dryness on the pill
yes,
because, as you said, if
yes,
our natural hormones are at menopausal levels,
yeah,
then it sure seems like it would contribute to both vaginal dryness and maybe even mild atrophy, even though
it
somebody's
does.
of reproductive age.
It does. And that's why one of the indications for vaginal estrogen is young women on the pill.
How ironic.
Yeah,
Interesting.
which is just kind of sad and crazy and weird to like rob them of their own estrogen and then give it back. Um, right. So, and then I think depending if it's a progestin only method, I mean, I think sometimes it makes sense. Maybe their effect on libido is less, or some women might not notice that. Some of the progestins are androgenic or actually testosterone like, so then you have to sort of speculate. I mean, they could have sort of their own libido enhancing effect in theory, although I've never seen that documented or actually been convinced that that's actually happening. And again, that sort of feeds into the why are androgens or testosterone like hormones sometimes libido sex drive promoting and sometimes not. And yeah, there's a lot else. Mhm.
Given the efficacy of copper IUDs,
Right.
why are they so hard to get? I mean, I know I'm asking
Yeah.
you to speculate here, but I find that 49 out of 50 women that I work with are steered towards hormonal contraception before being offered the option of a copper IUD.
I know.
And I don't quite understand why. Do you know why this is so difficult? And particularly for younger women, so women who have not given birth,
Yeah.
are often told that they're not even candidates for copper IUDs. And so
That's
is that true? And if,
that
yeah, I didn't think that
that's
was
not true.
true.
That's not true. No.
Great. Let's
Yeah,
dispel some of the fear, please.
yeah.
Copper IUD.
Let's do it. I mean, we should do a whole episode on this one time, but we'll spend, 5 minutes, 4 or 5 minutes on this. So through my decades of, being a naturopathic doctor and various colleagues over the years, a number of my naturopathic doctor colleagues have used a copper IUD as their method of choice. Is that your experience as well? Can you
Mhm.
sort of corroborate that? Yeah.
I don't know
Um,
anybody that doesn't.
right. Okay, so it's popular among naturopathic doctors. So that should tell you something. Um, I think it's also in certain corners of the natural health world, there's a lot of concerns potentially about the copper IUD. So it is seen in certain circles as being a problem. I think I don't want to dismiss that at all because I mean it is copper. I think there's a new lower copper IUD coming. I shared that on my social media. It's less than half the amount of copper, and the hope is this will make it easier to tolerate. Potentially, I think the different structure of it too will make it less painful. Um, I'm not. I mean, I haven't as a clinician. I've never been overly concerned about the copper and the copper IUD. Um, I think there is something just about having something inserted up through the cervix. I was just reading something about like just some people just from that even months later, like after the sort of procedure of the cervix can be because back to the autonomic nervous system. I mean, the as you know, the cervix is triple innervated, so it also has the vagus nerve going straight into it. So I think any kind of IUD procedure can potentially there does seem to be a sort of post IUD procedure anxiety that some women develop. And I would say that's not from the copper, that's just from the procedure. I think, but back to your question, why are gynecologists so they love the hormonal IUD. I don't can't quite explain it. I was just having a conversation with one of my patients actually just this week, and she was just saying every female gynecologist she's been to, they're like, I have the copper IUD. I love it. Like they're like little like preachers, evangelical, evangelical like preachers for everyone should have this. It's they really love it, and I guess it's primarily because obviously it can suppress. Well, it does suppress bleeding, so and it
Oh, so
can
not the
relieve.
copper, the marina. The
No, the marina hormonal
right.
IUDs.
Yeah.
Sorry,
Okay.
yeah. No, sorry. I hope I was clear. Yeah, the gynecologists love the hormonal IUDs. They just absolutely love them, and I think it's maybe more about how much they love them versus I don't know. I don't know why I don't know why the copper IUDs aren't offered more in a mainstream context because you think they would be because they're so effective at preventing pregnancy. Um, but copper IUDs can make periods heavier, and hormonal IUDs make periods lighter. I think for a lot of the doctors, it comes down to that.
Yeah,
Yeah,
I would agree. I think that there's still a really common narrative um perpetuated on social media and certainly amongst um medical doctors that periods are an inconvenience and
yeah,
of no value.
yeah.
And in the naturopathic world, I think like we just can't speak highly enough of the value of menstruation
Of ovulation.
and of ovulation, but also of menstruation, right? Like as a report card on the health, I mean, menstruation in and of itself, the cycling process, but yeah, of course, in connection with ovulation.
It's ovulation. The menstrual cycle, like an ovulatory menstrual cycle, is an expression of health, is a creator of health because it's how we make hormones. So, and almost every situation, apart from a few things, menstruation follows ovulation. So, I mean, you can't really have one without the other, except obviously pregnancy, um, except hysterectomy, except ablation, except the hormonal IUD would be the one situation. So I've written a few times that it's an interesting paradox that with combined methods of hormonal birth control, so pill, patch, rings, those ones, women will bleed an induced withdrawal bleed but not cycle. So there's no value in that. There's no medical reason to do that, to bleed monthly on the pill. Um, Conversely, with the hormonal IUDs, you you can actually cycle, as in have an ovulatory menstrual cycle, but not bleed, which is one of kind of a quirky compare and contrast. So this is why traditionally I have sort of felt like the hormonal IUD is the lesser evil, and that it does at least allow hormone production. Like it allows women, not all women, but especially the lower dose IUDs, women can still cycle, which is amazing. And even if they're not bleeding, they can track their cycles with basal body temperatures. But then along with it, though, was this historically this sort of wishful thinking around the hormonal IUDs that the levonorgestrel, which is the medication, it's not progesterone. There was this wishful thinking that it just stays in the uterus, it only acts in the uterus. But we know now that's simply not true. It it causes breast changes that are visible on imaging studies. It increases the risk of breast. That medication, like all hormonal birth control, increases the risk of breast cancer. It affects the brain. It affects mood potentially. And also, there was a study recently that came out that hormonal IUDs specifically strongly linked to hair loss, facial hair, and breakouts. That's the androgen testosterone like nature of levonorgestrel, the progestin. I would say that also potentially drives weight gain in women because any kind of excess testosterone stimulation will promote insulin resistance and weight gain. So yeah, hormonal IUDs are kind of not what some women signed up for, I think. But all that said, some women love them. So I do want to kind of leave space for everyone listening if they've had a good experience with the hormonal IUD. And I think that's okay. I think if they haven't developed those side effects from it and it has relieved heavy bleeding, and especially if they know they're still ovulating, it's like that's a win. That's a good technology.
Is there a lesser of two evils if somebody's choosing between a hormonal IUD and oral contraception? Do you have, did you say your preference is the lower dose
Yeah.
hormonal?
Well, my preference would be the hormonal IUD primarily because you can still have a menstrual cycle on it.
Okay.
You can still cycle.
With regard
Um,
to sexual desire, do you see
with regard
less
to sexual desire.
impact? I mean, well, as first I was asking about overall
No,
health,
I know.
but
Yes.
coming back to our main topic of sexual
Yes.
desire, do you see one versus the other having less negative impact on libido?
Just purely from a biology, physiology perspective, look, the hormonal IUD would have to have less impact. I mean, it's a lower dose. It shouldn't be suppressing hormones. I mean, I think it generally it would have a lesser impact on sexual desire unless it's happened to cause, mood side effects, in which case, or weight gain or something, in which case it's, indirectly going to have a negative impact. And I'd be curious as you in the summit, I'm curious, obviously get feedback from women. I'm sure we'll hear some stories about, confirming that or, disputing that, but there's going to be lots of different um, stories out there.
What about
Mm.
melatonin in this sort of confluence, right? So we talked a lot about sleep and how important sleep is. Something that I learned in naturopathic school is that
Yeah.
in parts of Europe, melatonin at high doses was given to suppress ovulation. It was actually a form of birth control.
Interesting.
Um, yeah, at like 50 milligrams, right? I never verified that, but that's
Wow.
what I learned
Yeah,
in
yeah.
endocrinology. And so I'm curious, I actually often find that even at low doses, people feel quite groggy and hungover after taking
Mm.
melatonin. And I'm curious about your thoughts around melatonin versus 5-HTP, how that may or may not interact with the rest of the reproductive cycle, and then the benefits around, like you were saying earlier, sleep and desire.
Yeah. Well,
A
I
lot
have
of dots
different
to connect,
top,
but
yeah, I have different top methods for promoting sleep. I don't prescribe a lot of melatonin anymore. I used to use it a lot more because it's obviously preferable to, sleeping medication, especially like the Z drugs or the Zopicone and all those. Like I would think, but melatonin doesn't work for everybody, and definitely it does intersect with the rest of the hormonal system. So it definitely, and I think because for example, I've been nervous about melatonin for children because I think it can, you know, interfere with or affect their like the communication with their brain and ovaries or brain and testicles. So I would be nervous, but I'm not an expert on melatonin. I don't use it very much anymore. Um, but I think, yeah, in answer to your question around how can you support sleep in a way that is also going to, potentially support sexual desire. I mean, my approach around sleep is a lot of nutritional things. So definitely magnesium. I mean, it's kind of obvious, but magnesium glycinate, glycine itself is can promote sleep through different mechanisms because it's a calming neurotransmitter and because um it also helps to lower body temperature. So I like harnessing the power of that. Part of the the initial sleep cycle or entering sleep is as your body temperature is dropping. So you can sort of harness that in different, and melatonin works partly in that way too, I think. But glycine will help with that. And the other way you can, it's just a little simple hack, but I am a fan of the like warm bath or shower like an hour before bed. And then you heat up the body and then it starts, as temperature starts going down, that can help pull people under into sleep. Um, yeah, there's a particular one of the magnesium supplements I'm recommending a lot these days is if I can get the name right. It's a magnesium acetyl taurate, like it's magnesium and taurine, but bound together, like so not just a magnesium and taurine, which I had been prescribing for a long time. So that seems to be quite sedating, working on the GABA system, anything that works on the GABA, any of the herbal medicines that help with GABA can promote sleep. What would you add to that list, Dawn?
Actually, I love 5-HTP.
Yeah.
Like so much more than melatonin. I like
Yeah.
5-HTP,
Yeah.
but usually 5-HTP, magnesium, and Melissa. You know,
Yes. That's a nice
was
combo. And then a lot of sleep is about what has been happening with the nervous system during the day. So, like I said, sleep is a whole body project. It's a whole day project, really. So
so is
it's about
foreplay.
so is foreplay. Yes, true. So it's about like sleep and sex are they're similar in some ways, actually. They're things that we can't really micromanage. We just have to like set the stage for everything to just sort of unfold as it needs to. But I think for sleep, like getting circadian rhythm, so getting outside in the day, especially in the morning, can make a huge difference. Avoiding alcohol generally is really important for sleep. Anything to do that supports the circadian rhythm, so that nice healthy oscillation between sympathetic and parasympathetic, all the signals of safety are going to support sleep later in the day, like even if it's 8 hours later, like having had, yeah, a less stressful day or an easier day will help for sleep. And that's especially true for those of us that are very sympathetically kind of adrenaline wired. I'm like the sort of really nervy, wiry types. Or just you can't just expect, you can't live go through your whole day like that on overdrive and then expect to just, 1 hour before sleep suddenly calm your nervous system down enough to, to go to sleep.
And what a great parallel with sexual desire as well.
Yeah.
It's like you can't live
Yeah.
weird all day and then just
No.
expect to feel turned on because somebody dimmed the lights. Um,
Yeah.
Laura, what are your thoughts on blue light filter glasses?
I wear them. What do you wear them or yeah,
I have
especially
I took them off for this because the lighting, when I'm recording, it's
yeah.
a little too much. But I, I don't personally notice a huge difference in my sleep quality if I wear them or not. I mostly notice the difference in eye fatigue because I spend too much time at the
Oh, right.
computer.
But do you wear them during the day or only kind of in the evening? I mean, I wear,
I wear them the whole time that I'm at my computer most
oh, I see. Oh, to protect. Oh, I see. Okay, that's a little
of the
different.
time.
Yeah. Yeah, I'm not sure. I mean, certainly I'm a fan of, getting more blue light, outdoor light in the morning and then less in the evening. But just back to your question, your thought about sexual desire. Like this is sort of a joke in our marriage, but like the biggest antidote to sexual desire for me is work. Like if there's anything work related, anything social media, any kind of emails, if I look at my work email, like sex is off for a while. Like, I need to put in between like a walk or just, holding hands or having a meal. Like there has to be something and maybe I'm sure it's not that strong for everybody, but just as an illustrative example, like I need to be a human, not a, not a worker. I need to like, come back into, yes.
Yes. So you brought up connection and something that I've been really curious about. I don't have a lot of expertise in. I'm hoping that you do. What are your thoughts on oxytocin nasal sprays and other, or, troches? You can get oxytocin in a variety of ways. Um, I'm told it's pretty effective at increasing arousal and
Yeah,
sort of shortening the orgasmic arc, increasing
I,
potential for
I believe
orgasm.
it.
I also read in a book a long time ago, maybe 10 years ago, reading a book called Go Wild, that there is some speculation that domestic abuse comes out of a maladaptive oxytocin pathway
Oh,
that with
wow.
heightened level, but, because oxytocin is so bonding that anything that threatens the bond becomes very anxiety provoking. And so the supposition is that in these individuals, if you threaten our bond,
Yeah.
right, then that is potentially problematic. And that's not to say that it could not be used responsibly, under medical supervision to support arousal. But like I said, I don't have a ton of experience. And so I was just curious, do you have experience prescribing it, using it, or are there studies that show how efficacious oxytocin is?
I have thoughts on it. I have not prescribed it. So no, I do not have, you'll have to find another, hopefully there's clinicians out there who, can give you some feedback on prescribing it. Through my biologist lens, it makes sense that it would improve this, enhance the sexual experience. I mean, it would be like a little bit like ecstasy or something. It would definitely be I mean, just through my biologist lens, I suspect it would be stronger than testosterone for that kind of thing. But it's interesting because we've already talked about the autonomic nervous system. Oxytocin is kind of part of the autonomic, it's not directly part of it, but it's very closely linked with the parasympathetic. So it's right alongside there. So anything you can do, all the signals of safety, all that can actually help improve oxytocin levels generally. But oxytocin does have a dark side. I don't know anything about the domestic abuse research that you're citing, but I do know there was some science about 5 or 6 years ago, which I thought made was very interesting. That it was talking about if you marry, like in men, so oxytocin is known as the cuddle hormone, the love hormone, and it is, but it's also the war hormone. So you marry testosterone and oxytocin in men, it's actually part of their potentially, I mean, this is what the research was suggesting, part of their kind of bonding as a tribe, as a group, to be ready to be aggressive to the outside
Yeah,
group.
it's actually really similar. Yeah, I think it's probably the
Yeah,
same research that we're referring
maybe.
to because what they were saying, right, is that the bonding is so strong
Yeah,
that the like you said, kind of the shadow is that
yeah,
anyone who's not part of our circle, right, the
yeah,
otherization of somebody outside of the group is also
yeah,
heightened, which can lead to conflict.
yeah.
Yeah, exactly.
Oxytocin it's a fascinating, it really is a fascinating hormone. It's a very human hormone, very mammal hormone. Um, Again, through my biologist lens. And just there is something in my latest book a little bit about oxytocin, comparing and contrasting. So a little bit off topic now, but on the topic of metabolic health and insulin sensitivity. So the research is pretty clear that estradiol promotes, is very good for improving insulin sensitivity. Is why we can tend to insulin resistance in the menopausal lower estradiol state. But there's also, of course, breastfeeding or postpartum is also a very low estradiol state, but doesn't seem to have the same problems metabolically. And actually, what the researchers think is actually this because in the breastfeeding state, there's a lot of oxytocin. And when the oxytocin comes online, that seems to mitigate or really sort of change the whole low estrogen landscape to something quite different. So they're actually looking at, yeah, oxytocin as a treatment for menopausal bone health, metabolic health, mood, um, potentially sexual desire, as on our topic today. So,
Okay,
yeah,
so I want to ask you now from the opposite direction.
yeah,
So we've talked about all of these various things, whether it's medications,
yeah,
pain. different things clinically that can
Yeah.
influence sexual desire.
Yeah.
So as we close out, I'd love to hear your thoughts on the opposite arc. How does sexuality, regular, and whatever it means for that person, I think we understand that everybody
Mm.
has a different natural
For
libido,
sure.
sense of desire.
Yeah.
But for somebody to remain engaged with their own sexuality
Yeah.
through aging, what are your thoughts on how that contributes to health and vitality?
Oh, that's a good question. It's an interesting question. I'm curious to see what some of the other interviewees responded to that. I mean, I guess I don't have a certain answer about that. I'm not certain about it. I mean, I do think it's my instinct is just biologically, physiologically, it's important. It's important sort of way to engage the nervous system. And that could just be with masturbation as well. I'll just point out, it doesn't have to always be within a
Solo sex
partnership.
counts.
Yeah, solo sex counts. And I ask my patients about it. I think it's good to just sort of really normalize it, that it's I don't know, like by, the question is by what mechanisms is that promoting good health? I mean, there's very fundamental things like it's promoting better circulation. I mean, it is good circulation for the genital area. And I mean, I think there's arguments to be made for that. Certainly for men, I think it's pretty important for their prostate to, for ejaculation to be happening. I don't know if there's an equivalent for women, but I think just in terms of, yeah, blood supply. What would you add to that, Dawn? What have other people? Yep.
I mean, I don't necessarily even need it to be about mechanism of action, but I
Yep.
find mood,
Yep.
the sense of connection,
Yep.
even energy, vitality. Like, I find that somebody who's really connected to their sexuality
Yep.
retains a sense of aliveness
Mhm.
and vitality,
Yeah.
at any age, which is one of the reasons
Yep.
why I think it's really important. What I don't know clinically, I've heard anecdotally, and I wasn't sure if you knew about this clinically,
Mm.
but I've heard of women who are um, really engaged with their sexuality, whether it's because of
Yep.
toxic practices like jade egg, or
Yeah.
just they've decided that in their relationship,
Mm.
sexuality will be a center point. Um, that they don't need, that they have less vaginal atrophy.
Yes.
Even I interviewed a woman, she'll be presented later in the series, but she teaches a practice called pompoir, which is like Kegels, but it's almost like Kegels on steroids. So she teaches
Mm.
women how to engage the anterior, posterior, and lateral
Mm.
sides of the vagina independently.
Okay, I'm going to have to listen to that interview for sure because that's
Absolutely. I
intriguing.
will send you all of her material. It's fascinating.
Yeah.
But she talks a lot about the health of the vaginal tissue and the health
Yeah.
of the vaginal wall, and then even the bladder health. But then it just has me curious about food and how you mentioned earlier, as human beings, we're very connection oriented. And
Yeah.
so, all of the health benefits of connection.
For sure.
Your thoughts on that?
Yeah. I mean, I think that's fascinating. I think if there are people out there observing that, regularly using your vagina, whether it's solo effort or, is would promote, vaginal health long term post menopause. I believe that. Especially if it's combined, I would just say, especially if it's combined with full nutrition, because I'll just gonna put a plug for zinc in there. Actually, I think being fully nourished with zinc, which is hard to do, which a lot of women are not, is important for the integrity and health of the tissue. So this might be for people who are finding other ways, who find they don't actually need vaginal estrogen after. Um, there's a whole other conversation to be had around the microbiome, actually, of the vagina and maintaining it long term, and that can be very important. So we didn't actually cover that as one of the, but vaginal microbiome is another sort of thing that can definitely affect someone's sex life. Um,
Now, with
yeah,
zinc, fully nourished
yeah,
with zinc, 30 milligrams, 50 milligrams, what is
yeah. Or I think either regularly eating seafood, eggs, red meat, and or taking zinc. Yeah. What do you think? I usually prescribe 30. 30 says, I feel like, and I'm, be happy to get your confirmation on this. I feel like 30 is quite a safe. dose. You know, you're not in the territory of depleting copper or anything like that. Like it's quite easy to do,
Do
always
you
with
give
food.
zinc regularly to somebody on a copper IUD?
I do actually. I don't know if that's necessary, but it sort of feels like it's just a, what do you think? Yeah.
I actually never have. I
Yeah.
don't think I use zinc enough, Laura. I think I
Yeah.
use zinc, the first sign of illness, I say take 50 milligrams with food 3 times a day. But it's not an
But
ongoing thing for
But of
me.
course, zinc is the sexual desire nutrient. That's why, you know, the story that oysters are an aphrodisiac, that's from zinc. That's their zinc content primarily, I
I
think.
didn't know
Yes.
that.
So I
So great.
um yeah, so zinc is a nice easy. I guess we're finishing with just like an easy tip here, but that would be both for maintaining good vaginal tissue health and also potentially acts on other aspects of libido. But yeah, back to your sort of question about the importance of that. I don't know. I'm always cautious because obviously my area is, you know, biology and physiology and hormones. It's and you're talking. This is more what we're talking about now is kind of more of a spiritual thing actually, and sort of how, you know, that kind of practice or being more of a sexual being is going to feed into other parts of women's lives. It makes sense to me. Even as you're saying it, I'm thinking, oh yeah, I wonder if I should, you know, incorporate a bit more of that into my life. So it's appealing, but at the same time, I don't want one thing I'm always cautious about. I don't want women to feel like it's anything is one more thing to fail at. You know what I mean? Like if there are women out there who just don't feel particularly sexual and maybe don't want to for different reasons, I don't want them to feel like that's a negative. I mean, if there's something about what you've just been describing or some of the other presenters you'll have that's appealing and interesting and women want to sort of explore it, but I think it can be, I don't think it's, yeah, I hope you hear what I'm saying. Like, I don't think it has to. There's lots of different ways to live a life, and
Yes.
I
Let's
don't
not
know that
add it
if
to the
being,
obligation list. That's
yeah, I don't
great.
want it to be one more thing to tick off our list. Like we have to be this, we have to be this, we have to be very sexual, we have to be, we have to be this, we have to be this. So I don't know how that will land with people, but I think there's quite a. I mean, there's a lot of diversity and variation in a lot of human experiences. I think there is quite a variation in sort of degree of sort of sexual engagement. What do you think? I mean, does that make
Yeah,
sense to you? Yeah.
I'm with you. I think there's a huge variety that characterizes normal.
Yeah.
I am really curious, I think, about, okay, so I think even in naturopathic and functional medicine,
Yeah.
we can get caught up in fear-oriented conversations. Um,
Yes.
you know, of this toxin, this mold, that food,
Right.
inflammation, right? Like in the same way that the conventional medical world, I think, often teaches people to be afraid of their bodies.
Yeah.
I think too often in the kind of holistic realms, we can inadvertently teach people to be afraid of everything outside of their bodies.
True. Good point. Yeah.
And
Yep.
I think that practices that improve resilience and vitality
Yep.
we could uplift them. And so again, my thought is if it improves your sense of aliveness,
Yep.
I almost fail to see how that could not have health benefits in terms of energy, stamina, just the desire to engage in life. It could
Because
be
what we're talking about
dance, right?
here,
It could be
a word that
something.
has,
Go ahead.
yeah, of the word, what we're talking about, and it hasn't, this word hasn't come up yet in our interview, but it's pleasure. So, I mean, we've been talking a lot about desire, libido. That's all kind of more clinical, but this is ultimately it's about women's pleasure. And yes, I mean, sexual pleasure is potentially a huge part of that and can inform or sort of broaden or widen the experience or the expectation for pleasure from a lot of things. Like just for example, for me personally, like just a little bit of sharing. I love being in the mountains. Like I love it, like love it. So that's either the, Canadian mountains where I'm from in Alberta, not that far from where you are in Montana, or the New Zealand mountains. And there is something almost sexual about it. Like it really is. Like it's like the intensity, the kind of euphoria of being there in surrounded by mountains is that kind of feeling. So I think from what we've been talking about now, I mean, maybe that can feed into each other, right? And of course, then being with my husband and having sex in the mountains is even like, that's even
There
that's
you go.
everything.
Yes.
That's that's everything. But yeah, so I think that's what we're talking a little bit about here. Yeah.
Great. Thank you for your thoughts on that and even your willingness to share. I appreciate
Yeah.
it. So we've covered so much ground and I'm so grateful. Is there anything that you wish I'd asked just because you feel like it's a really important part of this conversation around libido or desire? And it's like, oh, we just, there was this other little tidbit. If not, it's fine. Like I said, we covered
Yeah,
a
nothing I
lot of
can think of.
ground.
We have, and it is a big kaleidoscope topic, isn't it? It's like every little bit of it you could sort of drill down and talk about. Um, so hopefully, I mean, hopefully we've covered some of that. You'll be covering that with all your other guests. And you know what, Don, I'm sure there are things that I'll get off the call and think, oh, I should have mentioned, but we'll do that next year, maybe, or another time. Yeah.
Fantastic. Thank you for being with us and sharing your insight and your wisdom. And
Yeah.
also, you're not going to plug them probably, but I'm
Yeah.
going to show
Yeah.
two fabulous books. If you think
Yeah.
that your hormones are contributing to your sexual desire, your sexual performance, your
Yeah.
libido, any aspect of it, Dr. Briden's books, I'm calling you Dr. Briden again because when I have your book,
It's okay.
that's how
Yeah.
I know you. Just a fantastic resource. So thanks for your contribution just to women's health, the landscape of women's health.
Oh, thanks so much, Don. Yeah.